Hello, MedTech Insight enthusiasts. This is Dr. Jennifer Joe with my co-host, the fabulous Dr. Ami Bhatt. When Dr. Bhatt isn't hosting the show, she's running the Massachusetts General Hospital telecardiology program, which is where she is streaming from right now, and seeing congenital heart disease patients and teaching the Harvard Medical School. When I'm not hosting the show, I see patients in the ER, urgent care, and hospitalist settings. We both support and consult and do a lot of so many things that it's mind-blowing to me a little bit today. In a number of traditional med tech and up and coming digital health startups. We both believe that healthcare can be better both for the clinician and the patient. We both practice clinically, so Ami's going to give a little spill that what we say or do here is not reflective of our institutions or what our institutions believe. We are delighted and excited to talk about a couple of things. Before we do that, I'm just going to get through a little bit, some operational things. We are live and recorded every Tuesday at 12 noon Eastern time, where we interview two guests. We really adore and enjoy our audience members. So when we are live, if you are watching from Facebook, YouTube, or LinkedIn, please go ahead, let us know who you are, where you're watching from, what you're working on, and then any questions that you have for our guests. They are here and available to answer them, and we adore that. And if you're looking for the recorded shows, you can go to Vanguard.Health /MedTech Insights and also check out the recorded shows on YouTube, following me on LinkedIn, or following me and Ami on Facebook. So to kick us off, Ami, I don't know what you're going to talk about, but I would just like to say that we're delighted that our digital health textbook finally launched.
Yes, our first textbook in telemedicine and digital health and cardiology is out with Springer now and available. I should have thought to have a link or put it up. We'll do that next week. It's okay. It's going to be there. Thank you to so many of you who have already started purchasing it.
And it was a little crazy, like
and
within
posting
the first 24
pictures on social media. I'm feeling very special right now. But I really hope that you enjoy it. And I think the world of telemedicine digital health is changing. So our authors are fantastic and forward-looking and spent a lot of time thinking not only about where are we now, but where do they think we're going. So I would definitely pick up the book, take a look at that. And if any of them are right on where we end up, you should take them to Vegas with you, because there's a lot of predicting going on in this book, but I think a lot of it's going to be spot on. So again, Springer, Healthcare Information Technology, Telemedicine, Digital Health, and Cardiology. And you can look for Editor Bhatt and you will see it. Other exciting things, American Heart Association, what a weekend it has been. So much happening, real focus on diversity, on social determinants of health, on thinking about algorithms and AI, and of course, good old-fashioned cardiology and making people's health better. So a really exciting conference. And looking ahead, incredibly excited for the Consumer Electronics Show. That is happening in January out in Las Vegas, as it does annually. And several years ago, they began a healthcare platform. And so this year, we'll be leading discussions in artificial intelligence, thinking about where the field of medicine is going and how we can make it happen in a way that is unbiased. And so I say that excitedly, and also because Carol McCall, one of our guests today, has actually agreed to be one of the speakers at the Consumer Electronics Show. And the entire team there it's very exciting to have her as our we. So you'll hear some from her today, but if you want to hear more, she and I will both be at CES in January. I think that's all for announcements for today. We'll probably go ahead and get started because it's going to be a robust conversation. So with that in mind, let me first tell you about Carol McCall. She is the Chief Health Analytics Officer for ClosedLoop.ai. Carol is a health actuary and population health executive. She has expertise in advanced analytics and AI, health service innovations, and health economics. And her superpower is knowing how to integrate these things in a way that can promote health, accelerate equity, and help companies become learning organizations to learn what works for whom. Her background actually spans actuarial work, health plan, and PBM operations. She's also done AI and predictive analytics and health outcomes research. And then she studied the psychology of behavior change, incredibly important when we're thinking about implementing new technologies, personalized medicine diagnostics, and then national health information policy and public health. So really perfectly trained for this position as Chief Health Analytics Officer, ClosedLoop.ai, that is doing wonderful things. So why don't we bring on Carol first?
Wonderful to have you, Carol.
Oh, it's wonderful to be here.
Thank you.
Thanks for inviting me. And first of all, let me just start with congratulations on your textbook. You know, it's amazing how quickly healthcare is becoming digitized, and I guess that includes, you know, the curriculum as well. So congratulations on that.
Well, thank you. It's exciting, and I have to say that the entire thing was done during COVID. So all the people who wrote for it were working really hard and dealing with the stress of COVID at the same time that they were working on this for me. So I'm really grateful to all of the authors. So Carol, as I tell people about your bio, there are so many different things that have prepared you to be the person who you are today, really leading the charge in AI, both here nationally, but even globally. Will you just tell people a little bit, I've kind of given them your background, but about how you ended up at Closed Loop and what really motivated you to get there? And then we'll talk about the company.
Yeah, in some ways, I feel like it's even though I never could have predicted where I am today. I've been on this incredible journey through all these different aspects of healthcare. In some ways, I feel like it's an idea whose time has come, right? And so when I look at what's happening in healthcare, it's kind of this, immovable object and irresistible force. I mean, healthcare and healthcare organizations are under this incredible amount of pressure, and solving some of the problems, whether it's workforce shortages or movements to value-based care, and trying to deal with all of this, the digitization of healthcare and all of this data that becomes kind of too big to know. Some of the problems are only going to really yield when it comes to using AI to help kind of solve some of those problems. But it's also it's an idea whose time has come because something's got to give. When you look at healthcare, I think in 2019 we spent $3.8 trillion, and it's actually on a path to $6.2 trillion. And researchers actually say that 25% of it, so like today, $1 trillion of it is wasted. Mm-hmm. And I can imagine, isn't there another way that we could spend $1 trillion? Mm-hmm. And I think we've been through debates in Congress recently that say, yes, maybe there is. So, and that's not even over 10 years. That's every year, each and every year. And so I think, it's a lot of the technologies have become mature enough, and I think the organizations are ready enough, and in fact won't be successful under value-based care until they embrace some of these new technologies. I think that the industry is finally at the beginning of something where we can make deep and sustained changes that can promote health for everyone, and in particular, accelerate health equity so that we can address some of the disparities that have been far too persistent, and clearly quite evident during COVID.
So this is just a brilliant introduction to what we're talking about. And Carol's been thinking about this for a long time, long before everybody else. I guess two important things for our audience to recognize that Carol said there, and I just want to point out. So the first is, when we're talking about the use of artificial intelligence, right, we're actually talking about using it throughout the healthcare system. And so that 25% waste does not mean we're going to apply AI to be your next doctor and diagnose you, right? Is that part of what algorithms can do? Clinical decision support diagnosis? Sure. But there is a lot of administrative work that goes into running healthcare systems, delivering care, organizing pharmaceuticals, figuring out how to deliver the right workforce to the right place at the right time. And much of that is something that doesn't directly interact with patients. Instead, it is really fixing the system of healthcare that then actually makes things better for patients and for caregivers alike. And so, again, it's administrative AI that is a large part of this. And people sometimes forget that. They say, well, AI, I want my doctor. I don't want AI telling me what I have. And you say, well, changing the system means changing every part of it. And there's a lot of waste in the many different aspects. Carol, will you tell us a little bit specific about Closed Loop? I know you may have a slide or two. And as you're doing that, I will say the concept of being a learning organization is something that I have enjoyed talking to Carol about, because a lot of what we talk about with equity is something where we're not even looking back and saying, but what do we do? right? What are we doing and how can we learn from just what we do? Not looking outside, not looking elsewhere, just reflecting on ourselves. That's true with implicit bias in each individual, but it's also true with a system. So being a learning system is a lot of what Carol has taught me about. So Carol, let me let you take it away with Closed Loop.
Yeah, just a little bit about our company. We like to call ourselves healthcare's data science platform. And really that's because we are an end-to-end machine learning platform that has been purpose-built and is dedicated to healthcare and life science companies. And when we describe what we do, we really describe two pillars of technology. And so you can see that on this slide. So on the left side, we have, as I mentioned, this end-to-end, very robust, really workbench for data scientists. And what it does is it automates a lot of the different things that data scientists have to do when they're trying to actually build and deploy a model. And so we have very robust pipelines for onboarding all of the raw data, going through its cleaning and its normalization, and also enriching it with a number of different healthcare features, and then taking it all the way through from building it to actually deployment. And for us, deployment means getting it into a workflow, and that could be an operational workflow, like you had mentioned. It could also be delivering something to the point of care that a clinician can use to kind of augment their conversations with patients. It can also go into warehouses where it might become part of a broader kind of information and insight strategy that organizations are using to try to figure out what problems are the most pertinent for them to focus on and to solve. On the right side, the other pillar of technology that we have is it's a model template library. And so when we talk with customers, what we find is that there is a lot of commonality in terms of the types of issues that they want to focus on. So organizations come to us saying, we really want to address unplanned hospital admissions or readmissions, or we really want to focus on our ED utilization and see if we can identify people that are having kind of non-emergency use of the emergency room. Or they want to focus on chronic disease onset, or one of the more recent topics we hear a lot about is patients that crash into dialysis. And so this kind of emergency, dialysis initiation, what they're saying is that if we can get ahead of that, we believe that we have a way to kind of prevent kind of that emergency start, which has a lot of additional morbidity and mortality associated with it. A couple of interesting, if I move on briefly, kind of points for us have been, on the right side, you can see we were acknowledged in the class report last year as a top performer. And so this was their inaugural report on AI in healthcare, and it was our first time in the report, and we were given the top ranks of everybody that they had actually talked to.
That's great.
We were also given the top ranks, I think the 9th highest out of all the reports they'd ever done. But this becomes relevant because it's not just, it's certainly not our opinion of ourselves, and it's not even class's opinion of us. This actually, they go out to all of your customers and they talk with them about, what they liked about you, would they buy it again, what is distinct, and what's valuable to them. And everybody actually said that they would partner with us again, if given the chance. And I think on the left side, the other thing that's happened recently is that in April of this year, we were awarded top honors in the CMS AI Health Outcomes Challenge. And this was for us, this is for me one of my kind of proud moments in my entire career. And the reason is that it was an incredible field. This was a multi-year, multi-stage contest with more than 300 of not just the countries, but the globe's kind of leading organizations across academics and consulting firms and experts in AI. And when all was said and done and the dust cleared, this small company in Austin, Texas had been named the winner. And so it was really important work though, because I think what it did was it showcased the nature of what is possible, within AI. And it was more than an accuracy contest. We also had to focus on AI that physicians could trust. And we had to demonstrate how we would address algorithmic bias and unfairness. And so it was a really important contest, and we're really proud to have been named the winner.
That's fantastic. Well, what a great introduction to Closed Loop AI for our audience as well. Carol, let me ask you one or two questions, and we're about to bring out Jim Walton as well.
Okay.
So maybe actually, you know what? I'm going to pause for a second. Let's bring out Jim Walton, but then I'm going to prep you so you know what I'm going to ask, which is I'm
Okay.
looking on your graph, the class graph, and congratulations for that. And
Thank
I
you.
see the number of times on the bottom that somebody was offered the opportunity to do this kind of work. And I happen to notice Epic up there. Now, I'm not specifically talking about the organization. We don't have to, but I am talking about the point that you are a younger group than an established EMR that's out there who was maybe not designed to use AI the way that you guys designed yourself to do. And so let's bring Jim on because he's got insights into this too, and
Right.
talk a little bit about the challenge out there right now, which is taking the existing things that aren't designed that way and trying to transfer them or transition them to be AI like versus really just coming straight in and saying we're going to do this from the ground up. So hold
And
on to
as a
that thought. I'll prep you and let's bring
clarif-
Jim.
clarification question there, my understanding is you're a software overlay on top of an EHR, and just understanding that piece, and also if you have your own algorithms and you're just kind of the conduit for deploying them, or if you're
Right.
kind of a mix of both. But we will
Okay,
bring on
no, should
Jim.
we bring on Jim? And then okay. Carol, let's bring on
No,
Jim,
there's
and
just
then
so
we
many
want you to answer
clarification
this.
questions that
I
I
know.
have.
Jen and I have a lot of questions. All right, so let me tell you
Well,
about Jim Walton real quick so that we can
okay.
bring him out. Jim is a physician executive. He is the CEO for a large independent IPA in Dallas, Texas, Genesis Physicians Group. He's also the CEO for Genovista Health, which is an ACO of 340 PCPs in Northern Texas who care for 77,000 patients across lines of payer contracts. So CMS, Medicare Advantage, Medicaid, and commercial. Previously, he was a Chief Health Equity Officer and VP of Community Health Improvement for Baylor. Lastly, he also teaches healthcare, and so he's a great educator. But let's bring out Jim Walton as well.
Okay.
Welcome, Jim.
Thank you. Thank you for having me.
Great to have you with us. This is fantastic. So as you see, we're putting Carol's feet to the fire as we bring you in, but maybe just so that the audience knows who you are as well, beyond kind of what I said, would you like to tell them just a little bit specifically maybe about your CEO role right now and how the concept of kind of AI and algorithmic change and thinking about systems has become part of what you do as well?
Sure. Yeah, our organization chose to use Carol's AI solution for a new contract we entered into for Medicaid population in Texas. And our thinking was that, number one, we identified that we had a number of physicians who were very committed to the population that was marginalized and disadvantaged and experiencing disparities. Our goal was really to introduce the integration of social determinant of health interventions by community health workers with primary care doctors to create more credibility and more trustworthiness amongst the population that we were attempting to intervene with, to address, quality care gaps and social through the lens of social issues. So we felt like that using an artificial intelligence platform would make us uber efficient in identifying patients that would kind of drift to the top of the list by virtue of mixing data through machine learning that would help us see the mix between complexity and historic claims as well as community-based disadvantage that was in the public history domains, as well as using specific HRAs that would give us social determinants of health surveys that we would get for the patients, and stir that all in together to produce a risk score that then our staff could then identify the doctors who have patients, a preponderance of those patients, embed those community health workers in those practices, and then interface with their patients, but addressing their social issues, not just their clinical issues. So that's kind of our approach and why we're so excited to work with AI.
You give me more resources if you identify that my patients take more time, which classically women physicians spend more time. So there's data on that with patients who are very complex.
That's right.
Interesting.
Well, I would love that.
And the idea that, as you know, many physicians would say, well, I'm really not trained well, in medical school or my residency to address social issues, so I don't have a team or a staff that's trained. I don't have the time or the money to train them. So we kind of, through our ACO, we kind of layer that resource, but they're using the AI backbone to inform them of risk, a smart stratification. And we call it, through Carol's leadership, and her team, is kind of this explainable AI. So why did that patient land at the top of the list? And what are those explainable features around that patient's history or experience that would give us an opportunity to intervene on the social determinants as a strategy?
This is wonderful. Go ahead, Jen.
Massive for the patients, right? To get the extra these additional resources that they need to actually execute a well-defined healthcare plan, but huge for physician burnout, what we're calling physician burnout. So if you use that in a recruitment package, I'll send you my CV.
So
one extra resources to carry out good care is massive. Go ahead, Ami.
No, I was just going to say one thing I'll say is you use two words there, Jim, and you use them and they're very similar. So the first is trustworthiness, right? Yeah. Being trusted. And that is something that we're recognizing, and we should have recognized all along, right? Is incredibly important. And so not only is it for physician burnout, hard for, let's say, Jen and I to go out, I also may not have the cultural training yet. God, I hope I do. But right. I may not be able to connect. And I would assume that the people who are trained to do this, who are picking to go into the community, are ones who are trusted by the community, who may even look like the community that they're going to. We've talked about how important that is. And really recognize that the social determinants of health are such an important part of how population health actually, functions, and especially in our country.
Yeah, I think what's interesting is we're pairing this technology innovation with this human resource innovation. When they're brought together with the physician in the middle, you're creating a more trustworthy delivery system.
Right.
And instead of having the patient identified as the person or with trust problems, it's really the system that doesn't have that's not trustworthy, right? They're not credible. So we're inverting it and saying it's really not the person's issue, it's really the system's issue, and we've got to become more trustworthy. And so it's a strategy of pairing that together and bringing that in proximity to one another, close enough to where the patient could actually make the connection that the primary care is actually connected to their social reality, which creates more confidence. I think that they really see them as a whole rather than just a disease.
Right.
That's exactly right. Carol, your thoughts?
I was going to jump in there, and I think from an AI perspective, there's a couple of things that we do that try to enhance what the goals that Jim and his team have. And one of them, and I think it speaks to one of your questions earlier, how does it differ from, say, an EHR? And there are many ways, but one in particular is that we're really more data agnostic, which is to say our job is not to be a system of record, but to be a system of intelligence. And one of the ways we do that is we take in all manner of different data. So we will bring in data from EHRs, but we'll also bring in data from medical claims, pharmacy claims. We actually build into the system several databases that are publicly available around the social determinants of health. And if an organization has we have one customer that's built a proprietary HRA that is specifically a health needs and health risk assessment, and we can bring that in as well. And all of that becomes this kind of raw fuel that can generate the insights that go into the predictions. So that's one difference. The other, back to kind of, Jim mentioned explainable AI, what our platform does is, in addition to producing, let's say you're trying to predict who's going to have an unplanned hospitalization. And we will produce a highly accurate, highly quantified prediction, but asking you as a physician to trust that prediction without me kind of showing my work and explaining my answer is really asking too much. Mm-hmm. And so what the platform does automatically is it produces kind of an explainability factors, and it will give you chapter and verse. These are the specific factors that made this person's prediction be the level that it was. And it will show you the factors that contribute to higher risk and those which are more protective and contributing to lower risk. And in one particular case, we actually, because the platform, you can geolocate different things. It said, this person, I think their second highest risk was the distance that they lived from their most frequented pharmacy.
Okay.
And yet that could be a transportation issue.
Yep.
It's a real access to care issue. And in this case, it was contributing to low medication adherence, which was further contributing to the risk of an adverse outcome.
Oh, that is fascinating.
Brilliant.
Right. We can also calculate, one more example, is the platform's able to calculate whether or not someone lives in, say, a food desert, but it can also calculate if you live in a food swamp. And so recent research has shown that even more than living in a food desert contributes to, kind of adverse outcomes. And so all of this is fascinating, but what it does is it changes the conversation that you are going to have with that person and that patient about how to actually, what can they do and what can the system help them do to promote better outcomes.
And this is really, truly the movement towards value-based care, right? Not value in terms of value how we pay people, value in terms of what is the value of how we care for other humans in our country, right? This is what this is about. So addressing those social determinants of health and really recognizing how much better their healthcare will be if we can do this right. Let me ask two tough questions then, because somehow it's already 12:30. I don't understand how that happens. So Jim, you're the CEO of Genovista, but you still, have to talk to people and get people on board. How did you get people to agree to social determinants of health being at the essence of it? I mean, conceptually, I think this is wonderful, but I would imagine that there is probably some financial risk up front in setting up these kind of models. What's the argument that other people who are, I see a ton of clinician administrators on the feed, which is why I'm asking specifically for them. How are they going to, approach this? And what's the financial model that you sold people on, and how did you do it?
Yeah, it's a great question. I think, having the experience with the Medicare population and the commercial population, when we took on the Medicaid concept of let's go at risk on a Medicaid population. Let's think about that for just a second. A value-based arrangement that would pay you would be at financial risk. Most of our physicians, our primary care doctors, if you interview them, will tell you that the risk is the patient that they're not seeing. Their risk is the patient that's seeing Dr. Joe at the ER or urgent care rather than at the primary care. The risk is the patient who's not getting the preventive care, but has chronic diagnosis. So the idea that was, and we know that there's been a body of literature that has said that, that social issues are really the drivers, right, of the ultimate health outcome of populations, and probably the driver of health disparities, use of the ER, not using the primary care, not getting the preventive services. So it really wasn't a very hard leap, if you will, to say we're going to go with the more marginalized population. We're going to take financial risk for that population. We're going to try to up their quality scores. So the best way to do that would be social. So we as a physician, as a clinical physician community,
that's great,
taking a step. So the brave step was to say we already do clinical work fairly well. What we don't do very well is social. So let's just develop a social solution enterprise that connects to our clinical enterprise. And that would actually 1 + 1 would equal 3. So the problem was, though, is that we didn't have a mechanism by which we could find those people with the highest social risk. And so that was where Closed Loop came in. And that really gave people the confidence that we could actually find the people with high social risk that were more likely to respond to our interventions and drive more primary care preventive services, which at the end of the day was what the doctors wanted. So
that's great.
We'll see if we can actually make all that work. To date, the economics, the financial cost to the patient population isn't the problem. It's achieving higher levels of quality score in a state like Texas that has been a little bit regressive in its approach to these types of problems for generations.
That's
So
great.
we're moving the needle on that, and we're going to get there.
And how long have you two been doing this together now, just so our audience knows?
2 years. I think we're coming up in April. It'll be our 2nd-year
I
anniversary.
think so. Right.
So,
That's
Right.
great. And for those who are wondering in terms of looking at outcomes and when you do start to see that needle shift, did you see it right away? Are you seeing it now? Are you still feeling like you're putting things in place to see that shift? How does that look to you right now?
yeah, just for me, Carol's team was fairly efficient. It took us a few months to get that all working, and then COVID happened. So we really launched in the COVID pandemic, which really slowed us down. So I don't know that I'm a really good representative of some of the customers as they've launched. I would say we're still pending. I would say in April or May or June, we'll start to see correlation between what we've been doing and closing care gaps and getting primary care visits and stuff like that.
That sounds great.
Again, that's our real goal, is to improve the health status through the quality and primary care connections. We know that's ultimately going to play out to reduce costs.
Lovely.
yeah.
Gosh, Jen, I really love having like insightful doctors, CEOs of health systems on the show. Isn't it the most refreshing, like wonderful thing? I really,
Because he called out
that's
Texas.
great.
I hang out in Texas.
No, because he
I've
has
heard
great
that the second
vision.
time you said that, Jen.
I
I'm coming for you.
Good.
Come
So
on
before,
down.
that's right. So before we have to close out, and that time is coming, Carol, you've seen this field come so far, and now you yourself are kind of moving it. And like you said, it's a behemoth of a healthcare system, but it can be done. What do you see, both for ClosedLoop.ai, but also just for AI in medicine over the next 2 to 5 years? Where do you think we're headed, and what do you think everybody listening needs to really pay attention to for us to get there?
Yeah, I think a couple of things. I think the first is it has nothing to do with technology. I love working with Jim because I think that a lot of this begins with a paradigm shift and seeing a broader system, the true systemness of it, and moving beyond just a biological paradigm into a biopsychosocial paradigm. And when I think we open the aperture on that, and I think there's so many more opportunities that we see, to actually affect real change. And so I think that that's the first thing, and I can, you heard me talk earlier about it's an idea whose time has come, but I am a fervent believer that we won't be successful unless we embrace these technologies to actually try to solve these things. And so I am seeing a lot of interest. So I think I'm not the only one who feels that way. And for companies that are not pursuing this, what I would say is you need to start, because if you're not considering it, you're behind. I'm going to be honest there. Because even, what was it? It was October 20th so last month, about a month ago, CMS basically popped their head up and said, we are going to relaunch our strategy for CMS and for their innovation center. And it's amazing. What they said was, in this reshaping of our strategy, we have now 5 key goals. And the first one is to drive accountable care. And so if you thought it was getting driven aggressively before, hang on, because they intend to have all of Medicare and the vast majority of Medicaid beneficiaries in an alternate payment model by 2030. Their second goal was putting equity front and center, which was music to my ears. But then, and the rest of their pillars were very strategic in basically saying, we are going to partner with private industry to do more to help make this happen. And so if you're not working on it, you're behind, but you're also going to find a helping hand, I think, more than we have found in the recent past. And so that's a good thing. And so find problems that are meaningful to your patient population. So pick well, lather, rinse, repeat. So find something where you can get success early and build momentum within your organization so that people are enthusiastic for taking on the next problem. And if you don't know what those key problems are, come knock on our door, because if you bring us data, we'll help you identify, what those most important ones are. That's part of what we do.
Yeah, it's such great advice, Carol. Thank you. And I will say, if you don't know what those problems are, Also, just listen to your physicians and your nurses and your
Yeah,
patients.
they
You will
know.
hear themes. You will hear themes immediately if you just listen.
Right.
And I love that idea of what we call crossing the finish line, or quick wins is what Jen and I like to call those.
Yeah.
Things that
I-
teach people that technology will get you there, right? And I think that's
So
important.
Ami has little boxes in our textbooks that says this.
Yeah, we do. We literally have box outs in the textbook that say exactly that. It is. I'm
Like,
so excited you
I
said
need
it,
to
Carol.
put a box that says quick wins in
That's
various
right.
chapters.
Yeah. It's important. You need momentum. You
Yep,
need momentum.
that's right.
I wanted to say two things. I love and adore this. The EHR was originally a billing mechanism, and it's really structured in that way so that we have moved past the ability to quickly drop into a dashboard where we can quickly understand what's going on with the patient. And it used to be that we really recognized the relationship, the social determinants of health. And we had notes there. The dog's name is Rufus. So we ask about we need triggers. We're not, but and we had more knowledge of this. Or one of the three key decision makers with this patient are the daughter, the son-in-law, and this other person. And Carol, like, the fact that you built essentially, what am I hearing it correctly, a dashboard that really allows us to see that in a meaningful way, I think is huge. And the second piece I'm just going to drive home here is I love this relationship that you have with Jim and yourself.
Yes.
When companies are thinking about dropping new technologies in healthcare, sometimes, or a lot of times, they get confused that we can deliver healthcare with just technology alone. But I see that the biggest benefit is when technology is partnered with services to really enhance that care. And I would even argue that you can't do it with technology alone. I will be impressed. Humans are humans. You're always going to need the human touch. So the fact that you guys are pairing sophisticated technology with caring physicians who are going to reach out, and Jim's going to help me with my physician burnout for my difficult or patients that need supports that I'm not necessarily as trained or have as much time to do, I think is incredible. So really love this solution and this partnership. I don't know if you want to close out for today.
I am so grateful for the two of you, for the work you do. I'm so honored that we all found each other and are able to kind of follow each other's careers and push this forward. I have to say, for our audience, the kind of CEO that Dr. Walton is, that has that forward thinking, that really puts the patient first. There are many of them out there, but he is kind of one of those stellar examples. And to have someone with Carol McCall's expertise, who has lived so many different lives in healthcare in the United States, and is now able to see what has to happen for us to be better. And she said it right. If you're not doing it, you're already behind. There is help coming. I'm going to be very specific about the it. If you're not a learning organization who is using AI with the amount of data that's out there to help you figure out how to be better, just be better. If you're not a learning organization, then we're probably not doing the right thing. And we have to figure out how to, at least at a minimum, consider yourself that in whichever way you can. So with that said, again, Jim Walton, Carol McCall, Jennifer Joe, as always, thank you for a great 45 minutes. I wish we could have more time, but perhaps we'll have to do this again next year and see where we've ended up. And for those of you who have enjoyed this conversation, Carol McCall will be at the Consumer Electronics Show on our health track day in digital health, talking about bias in AI. And I have the honor of being there with her. So hope to see you guys all soon. And for our audience, see you guys on Tuesdays. We'll be back soon.
All right. Thank you both.
Thank you
Thank
very
you to our
much.
audience. Thank you to our guest.
Enjoyed it.